everyone. My name is Adaira Landry, and I'm an emergency medicine physician at the Brigham and Women's Hospital. And I'm excited today to be joined with Dr. Resa Lewiss on this EchoNous podcast, talking about her journey with ultrasound and her experience as an educator within industry, picking devices. It'll be a great conversation. So thank you so much, Dr. Lewiss, for joining us.
Thanks for having me.
My first question for you is, you've had a very interesting life. I mean, you went from, you started out as a resident and chief resident, at the Harvard affiliated emergency medicine residency. Now you're a professor of emergency medicine and radiology at Thomas Jefferson University Hospital. And you're a creator and host of a podcast entitled The Visible Voices Podcast.com, where you talk about healthcare, equity, and current events. In addition to that, you are an expert within ultrasound. So I'm just curious, you do all these things. I really want to focus on your ultrasound experience. How did you get into this field? I mean, there's so many options when you're doing an emergency medicine residency as far as which niche you want to carve out. Why did you choose ultrasound?
So it all started in Boston, in the exact hospital you're in right now. I was a resident in the second full class at the combined Harvard residency. The years were 1997 to 2001. And truth be told, we were not learning ultrasound in residency. There were 3 people that I saw using the technology. And the theme I saw for all 3 was it was in remote or limited resource situations. So there's a dear friend, they're all dear friends still to this day, James Lee, Hillary Cranmer, and Everett Lynn. And I won't go on at length, but suffice it to say, between the 3 of them, they had either worked in rural emergency departments in the US, inner city, crowded, limited resourced conditions in the US emergency departments, and finally in global health situations in developing countries.
And so you were thinking that you would join in that endeavor as far as going towards limited resource environments, or what were you thinking as far as how are you going to incorporate ultrasound into your practice?
Global health was definitely an attraction. It seems to be an attraction for many med students, people going through medicine. But I actually, I really respected all 3 as clinicians. It seemed to make them better as clinicians and better able to take care of patients. And that was the compelling part for me.
Yeah, that was actually similar to me as well. I wanted to emulate the physicians who I thought were really, really great. And I loved watching them perform their ultrasound at the bedside. And I said, oh my God, I really need to learn this skill. So that was what drew me in. I'm curious, as you have, spent the last 10, 15 years or so developing your niche, what has been the best part about learning ultrasound, performing ultrasound?
So there have been a few things. If I can say that from that initial exposure, I still had to make the decision that I was going to pursue this as my subspecialty within emergency medicine. And what really clinched it was the year when I finished training. I was working in the community in a community hospital, and overnight we didn't have ultrasound services. And one of my colleagues who had trained at another Boston program knew ultrasound, utilized ultrasound, and made patient care decisions overnight. And I didn't have that same ability. So the opportunity came up to do an ultrasound fellowship in New York City. They were providing housing. The program was. I liked New York. I had some friends there. I'm like, why not? And one of the key parts of this story is those 3 people I mentioned to whom I looked up who had used ultrasound. One said to me, Resa, why are you going to do another year of training? Ultrasound has not gone anywhere, and it's not going to go anywhere. And it's the only time I've ever not listened to this person as a mentor. The bottom line is I went and did a fellowship, and all of a sudden ultrasound took off. So I've seen this evolution from 2002 to now 2020. And what I can say in summary, when you say, what are the best parts? It's people, the community. It's an amazing community in terms of, it's one of the reasons why you and I work together, know each other, and really like each other. And I think many of us are really driven by quality, good patient care. And I think time and time again, as the number of applications for which we use ultrasound grows, as studies come out, and we've seen the evolution of the literature from case reports to case series to prospective convenience samples to some maybe multi-center studies, time and time again, ultrasound seems to win.
So how are you incorporating it into your career development? Sounds like you did it at the beginning with fellowship, and sort of where have you gone with your career in ultrasound since then?
So I would say there's the 80-20 rule. Like 80% of us identify as medical educators and 20% identify much more as researchers. When you have an academic position, you have to do a little bit of both, but most comfortably, most naturally, many of us are educators. So I started doing a lot of courses, teaching regionally, locally, nationally, internationally. So I actually, it was because of ultrasound that I've seen the world, and I've made colleague friends all over the world. And it was sort of this sort of reinforcement of, at the end of the day, patients are patients, sick is sick. And those of us that are motivated to take better, safer, quicker, more efficient care are really attracted to the technology.
But it's also giving you leadership opportunities. You're the director of your Point-of-Care Ultrasound division, correct?
Right. So I have, I've been the director of 3 different divisions. The first experience I had as both a fellowship director and a division director was in New York City. Then I had the same experience in Denver, Colorado, and finally here in Philadelphia, Pennsylvania. The difference being I wasn't wearing the fellowship hat in Denver or here in Philadelphia. But in all 3 cases, I saw this need and this way of building a division. And that has changed over time because ultrasound has become more established in the practice of emergency medicine. So certain aspects have become easier.
What do you feel like has become harder? And what has been the hardest part of your journey? You know, coming into a field that may or may not be more based on technology, and there's a lot more male dominance within the field. What has been your experience as a woman within ultrasound? And then also practicing in different environments. I mean, it's pretty tough to change your career across locations geographically as well.
So I think actually that's one of the beauties of emergency medicine, and many of us change it because you can move, right? I think in academics, we don't see it a lot. In fact, some people stay in the same place for their whole career as well as their training. I actually have loved and welcomed the changing, because I found with each, I call them chapters, with each chapter, things have been better and better and better. And I found certain things cement, specifically when it comes to ultrasound and ultrasound leadership. One of the most difficult things that I've seen, and this has been no matter where I am, and this is just true in general, and this goes back to why you and I share a love of reading books and articles on leadership, is leading people, having difficult conversations, and establishing culture change. So it is still, in this day and age, difficult to have all of our colleagues, specifically, I would say our operations teams at our emergency departments, understand that everybody is responsible for the ultrasound equipment. Everybody's responsible for the ultrasound equipment. In fact, I actually have found that a lot of times people don't really, something doesn't sink in until you get it in writing. And in terms of actually the academic career, I did realize a few years into my time in New York City that if you don't start publishing and putting your name in writing with your subject matter expertise, in this case, ultrasound, then it doesn't give you much credibility in the community. So we recently published this piece in POCUS Journal about how a successful workflow involves many members of the team. And those members of the team include biomed, IS&T, your healthcare record team, your clinicians, yes, your ultrasound division, and then your operations team. And the analogy I like to use a lot is the EKG machine. When the EKG machine goes down, they don't call the cardiologist. When the head of the otoscope gets stolen, they don't call the ENT doctor. But somehow early on, none of us are above doing anything. And we were the ones to help fix the equipment, navigate mailing, loaner parts, being on the line for sometimes hours with the applications and operations and sales divisions of these companies. And, it just doesn't make a lot of sense for us to be the one handling all the equipment. So one of the most difficult aspects, I would say, is moving the needle, establishing that culture change of responsibility. And it's not because any of us shirk responsibility or unable to make phone calls or unable to go to the mailing services, it just really isn't the best use of our time and our knowledge to handle that piece. Yes, we often need to know specifics of transducers. Yes, we might know the correct sales rep, the correct applications rep, but I think the more you can streamline that piece of your workflow for patient care, the better.
Hmm. And with your experience, navigating ultrasound within the, academic environment within your department, and then also I know you've had roles within national organizations as well. At some point, you decided to interact or collaborate more with the global industry of ultrasound. And I'm curious how you started to transition and really expand your reach beyond just academia.
Yeah. So I would say, first of all, being a part of those national organizations has what has led me to say that the community is amazing, because I've had the opportunity to get to know so many of the POCUS people in almost every state in this country, and certainly internationally. And so you just realize what a great community we have. My actually interaction with industry was very early on. It was, and for the sake of the discussion today, I won't name specific companies, but suffice it to say that I've worked with almost every company here in the United States and quite a few internationally. But early on, I wanted to teach internationally, and I needed a machine to bring with me. And so I developed a really collegial relationship with a representative that essentially always sent me a machine that I could check in with my luggage everywhere I traveled. So that was one of my initial. You start developing relationships with people within companies, and there is a trust. And none of us are naive to what's happening. Like if you use a company's machine, and then you tell your friends, and that's what the trainees who attend your workshop use, they start being comfortable with that machinery. The same is true in your residency program. If your residents learn ultrasound on a certain company's machine, if they leave and go work somewhere and have a decision-making role, they're going to choose what they trained on. So the whole process feeds into. Same thing if you're doing global health missions, education workshops, if you're, fill in the blank and you publish a paper, almost always in the paper, you acknowledge the machine that was used to perform the ultrasound examination. So, it's everybody kind of understands the terms of the relationship. Mm. So, an inevitable and necessary part of leading a point-of-care ultrasound division is interacting and getting to know industry and companies. And I have always felt that the responsible thing to do as a division leader is to expose certainly my other faculty and fellows in all the places I've worked, we've had a fellowship, to companies so that they can start having those dialogues, start learning how to communicate. This whole concept of communicating with industry is something that fellows will say they want to learn. And it actually is a skill that you come to just take for granted, but what do you say? What do you write? How do you call? What do you ask? What's askable? It's sort of, you and I have talked about playbook. There's a bit of a playbook that you learn. It starts with basic human interaction of developing a relationship. And then I think also understanding within companies that, there's a salesperson, there's a rep person, there's often a regional manager, there's a national manager, and depending on where the company's based, there might be an international. So sort of realizing everybody's role and what's in their scope to be able to make decisions. And I also started seeing my colleagues starting having greater roles within industry. And I think, like most people that are in leadership positions, I wanted to sit at the table. I wanted to be a part of the brainstorming. I wanted to be tapped for my ideas and my thoughts. And it was a little challenging for me to understand how to get into that place and how to have those roles or have those opportunities. And a lot came from speaking with friends in ultrasound who basically put my name forward or invited me to join meetings. But it's something that has come over time, and it's certainly a part of running a division to have those kinds of relationships and that kind of communication skill.
Why do you think, though, there's some hesitancy for doctors to really formally engage with industries, sit on their boards and work with them directly? I mean, there's such a strong relationship between what we do and what they provide. Why is stigma associated with being a part of industry?
Well, I mean, it's not limited to ultrasound. It's in, many aspects of medicine, and certainly in emergency medicine, when I was in training, the way we interacted with companies and industry for like sponsoring dinners or providing education materials was very different than it is now. And the thought being that there's no way, in fact there have been studies published in the New England Journal of Medicine, there's no way that you can be unbiased when that's happening. And I think one of my ways of rationalizing that is by telling companies like, listen, we're not to the best of our ability, we're non-denominational. Like, we will engage and we will talk to more than one company. When we have a workshop, there will be more than one company represented. When we buy, we're going to look at everybody. We're not going to just look at one company. And so I think there is that sense of being unbiased, and that sense of trying to not be swayed by money. And again, this goes back to, there have been some pretty clear publications about, companies buying gifts, companies sponsoring trips. And I mean, that certainly was all during my growing up and my time period in medicine that those things were happening.
Yeah. But it seems like there's a little bit more control and regulation over that today. And
Correct.
It's a great educational opportunity and a great networking opportunity and a career development opportunity for someone to really engage in the way that you described earlier, as far as sitting at that table. And so, in your experience, what do you feel like you've learned from sitting at the table of these powerful companies in our field?
I think, number one, it's sort of fun to hear the conversation. You get to know people, you get to know their personalities. You hear your colleagues. I'm a huge believer in, hearing what your peers are saying. So number one, you, as a listener, you hear what people are saying and what's working, what they're doing at their shops. So that's a huge benefit. The other thing is, in medicine, we are sheltered from so much. Like, we're sheltered from managing finances. We're sheltered from management of how companies are structured. And I think that by sitting at the table, by having those conversations, by attending, for example, board meetings, you start understanding the way the business world works. Because, and this goes back to, the Harvard Business Review, a lot of articles in that publication are relevant to medicine. I think people don't want to see medicine as an industry. They don't want to see medicine as a business. It unfortunately is. It is. And it doesn't take away from our Hippocratic Oath. It doesn't take away from our commitment to patient care and patients first and integrity, et cetera. But, the money, the monetary aspect is what drives the U.S. healthcare system. And ultrasound's a microcosm of that. We as ultrasound division leaders, we have to know CPT codes. We have to understand coding and billing. We have to defend our presence and the need for us in the department, because we're doing not just education and quality patient care, but also these are a billable procedure. So there's a lot caught up in what seems like just, pure altruism for patient care. There's more to it. There's more to it. It plays into the ongoing functioning of an emergency department, of a hospital, and of a hospital system.
So knowing all of this, I mean, you've had an extensive amount of experience on the front end as an educator, and then now as on, in the back end, as someone who is formally associated with industry. How do you decide to buy a device? I mean, this is a very hard decision tree for many people. And as someone who's been exposed to all surfaces, how do you decide what to buy? What are you looking for in 2020 and going forward in a device?
First off, I'll say that by being an educator, by sitting at the table and listening for many, many years, it prepared me to know the right questions to ask. I've had so many experiences with industry that have really woken me up, really opened my eyes. And it's unfortunate, but we often learn from bad interactions. We often learn from bad experiences. And so what I say is, every company is interested in selling you their product. And some are aggressive, some are less aggressive. At the end of the day, when I'm making a decision regarding purchasing, it's what is the best quality product that I can get for the money that I'm going to spend. Now, one of the great things is it's not my money, and it's not a limitless amount of money. So I often have a very set amount of money that I can spend to purchase equipment. And I've developed a system, and it's not unique to me. This is from getting the input of colleague friends of, inviting companies to come, showing me their wares, and then we try them out. And so a lot of people think that, I try them out. It's my opinion. And if the representative stays with us all day and shows us how nicely the equipment functions, then that's going to sell. And I will tell you, what I want is a company to leave the machinery with me, and I want my least experienced faculty to use it, because that says to me, can they figure this device out? Can they get good images without the help of me or the help of someone who's really, really experienced? So I think it's very compelling when machinery is liked by the non-fellowship trained faculty. I think residents, when they react with like big eyes and get excited over the aesthetics or the health design aspect to a device, that's also a big selling point. So it's often not about me and my thoughts. It's a lot about what I see the responses are of my trainees and of my less experienced faculty, because those are the people that I want to make sure are going to use the machinery and engage with it and not be afraid of it because it's too complicated or too overwhelming.
Are there particular, I love that idea, like you have to sort of try it out. It's such a complicated process, and so it makes sense to have it in-house for a while and sample it. Are there particular features, however, that you feel like starting 2020, moving forward with COVID, with the pandemic, infection control, that you feel like you must have now going forward?
It's a great question. And I think many of us are thinking about this. And, health design, I really like the field of health design. I think all of us are health designers as ultrasound subject matter experts, because we are involved with device and device development. We are involved with education models. We are involved with infection control and workflows. This is all health design. So I do think that in terms of purchase, in terms of looking at devices that are going to do well, I think a device that has a really solid cleaning ability, meaning like a keyboard, like whether it's a flat keyboard that doesn't allow nooks and crannies where dirt and liquids can get in. That's one example. I think one of the biggest things, no one has solved the EHR, the health record integration easily, seamlessly with a machine, easily, seamlessly then with PACS. So I think that IS&T aspect, which honestly is discussed at almost every industry roundtable that we have for ultrasound at almost every conference, that seamless interaction is necessary, kind of a plug and play, ready to go. And it's hard because every hospital is a little different. Their IS&T is different, their Wi-Fi is different, their PACS might be different, and certainly the EHR might be different. So that part's hard.
Yeah, it's tough. And also thinking about how your users are going to use them when they're remote. So your students now are no longer at the bedside with COVID as much as they used to be. And so how are we training our students in a remote fashion? So I think the ability for it to be very portable and potentially something that a person on the individual level can own, I think is a new consideration, because the cart-based systems potentially will limit the reach in a way where, in a world where we're socially distancing.
So I think you identified something else that's going to be very important, and that is teleguidance. And we've seen teleguidance. There are a few companies that allow teleguidance, and we were using it first for places that had limited resources in terms of faculty or limited resources in terms of people comfortable with ultrasound. So, some of the first trials we did was doing global health education, where there would be ultrasound experts here in the US, and we were working with people outside the country and other countries that were trying to use ultrasound for patient care. That's moved now to, some of our colleagues in California are running a remote fellowship where they do a QA weekly with a fellowship that's developed in another country. And what COVID has taught us with Zoom technology and with the companies that provide teleguidance is, you're exactly right. You don't have to be in the room with the person performing the ultrasound. You can, limit the exposure and contact of healthcare worker to one who may not be completely comfortable with ultrasound, but you can remote in and talk to them and help guide their probe manipulation and their image acquisition. And it's remarkable. And I think that is a must for any company developing a product.
And to add to that, probably we should talk about artificial intelligence as well.
Mm-hmm.
And so have you been able to sort of see that and works with ultrasound?
So I completely, AI is like this sort of trendy term that everybody's using. It's sort of like, there's terms that become trendy. So certainly one of the trendy terms and the trendy necessities right now for ultrasound is AI, artificial intelligence. And I don't say trendy to kind of minimize it or to say that it's not important. It is absolutely important. And I think you see now companies trying to keep up with that. I can say, full disclosure to the audience who's listening, like, so yes, I sit on the medical advisory board for EchoNous, and, I've had the ability to use their device for educational purposes at my institution. And I did what I talked about just a few minutes ago. It's a little less about me and a little more about what do my trainees think, and are they finding it user friendly? Can they, what wows them? And the concept of measuring an automated ejection fraction is pretty cool. The concept of labeling, automatically labeling where in the body you are and specifically what structures, that's also really attractive. I do think that sometimes companies think that that's going to be a huge selling point or that's going to carry them and sustain them. And I think it does initially for the beginner. But that's someone, once you have everybody's got a learning curve. Once the beginner learns orientation, once the beginner learns parts of an organ, I think that has a limited utility. So I think for all the companies that invest in the education packages and the learning at the bedside, and I'm a huge believer in just-in-time learning, like it gets people going, and it's usually the people that are less experienced. But I think for it to have an impact, the education and the AI needs to reach the people that are advanced beginner or maybe even intermediate.
I love this. I love this conversation. I feel like we've covered a lot, and I love this idea of ending on the concept of a learning curve, because just looking at your career, I can sort of see the evolution and how you've learned more and more about the field and yourself and your leadership skills and where you can integrate. So your learning curve has been awesome to hear about. The other things that we discussed that I think were really important are this concept of mentorship and who you're around early on in your career that really shapes you. It did for both of us, because we were around people who inspired us within ultrasound. We both pursued that field. And so loving the people in a particular area and that exposure is incredibly important. Lastly, I love this discussion about the intersection of medicine and industry and how there's so much overlap, and we really shouldn't divorce the two, and we should try to sit at the table, be part of the discussion, and sort of think about our own biases, of course, but how we can integrate that knowledge into our careers and our development and how we practice at the bedside. All those areas are important. And lastly, it's 2020, almost 2021. What are we thinking about as far as device development, healthcare design, purchasing items that are going to be sustainable in a pandemic that's still continuing on, where we're socially distancing, we're stretched as educators? How can we continue to teach people when we're not at the bedside? Thinking about teleguidance, artificial intelligence. Amazing discussion, Dr. Resa Lewiss. I'm so glad we were able to have you on. I'm so glad we were able to see your learning curve and what all you gained from the field of ultrasound. Thank you again for joining us.
Thank you so much for the invitation. I completely enjoyed the conversation.
Take care, everyone. And if you want to learn more, feel free to visit us at EchoNous.com.